welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Everyone, my name is Nick McPadden. I'm a PGY2 critical care pharmacy resident at Brigham and Women's Hospital, and today I'll be presenting this journal club on Cephalexin twice daily versus 4 times daily for the treatment of urinary tract infections diagnosed within the emergency department. So for a little bit of background, UTIs are a broad classification that include any infectious process of the genital urinary system. So we typically think of terms such as cystitis, pyelonephritis, urethritis, can also include things such as prostatitis as well. Symptoms often vary between individuals and within our patient population. So typical symptoms that we do think of, though, would be dysuria, polyuria, or a sense of urgency, suprapubic discomfort, and then systemic signs and symptoms of infection, most notably fevers and chills. And then typical bacteria that we think of, especially in the realms of this trial, we looked at E. coli, K. pneumoniae, and P. mirabilis. However, there are several other very common bacteria that we think of, especially in the outpatient realm and within our ED population. So that could be Enterococcus, Staph aureus, Group B strep, and other forms of strep and staph as well. So previous evidence, the 2011 Infectious Disease Society of America guidelines do recommend sulfamethoxazole and trimethoprim, nitrofurantoin, and fluoroquinolones as first line for treatment of UTIs, and that is mostly due to the better bioavailability, the higher level of tissue penetration, and then they also cite lower incidence of side effects. However, these guidelines were published when resistance rates were quite low for these first-line recommendations. So when they were first published, the resistance rates were documented to be sub 10%. However, as time has gone on, more and more of these agents are prescribed for the treatment of UTIs and other infections within these populations. Resistance rates have now been cited to be between 20 and 40% for most areas, and even greater than 50% in some areas as well. These recommendations were also from previous evidence that had suggested that treatment success rates were lower and rates of recurrent infection were higher with our beta-lactams as well. So the first 2 trials that we're going to be looking at, just for a little bit of background, would be amoxicillin clavulanolate versus ciprofloxacin for the treatment of uncomplicated cystitis in women. And this was published in 2005. So our patients were randomly assigned to receive Amox Clav 500 125 milligrams twice a day, or ciprofloxacin 250 milligrams twice a day for 3 days, and they were followed up for 4 months post. The primary outcome was clinical cure rates, and they found that ciprofloxacin had a much higher clinical cure rate when compared to Amox Clav. However, one big thing to note when we think about this study is that the dosing for Amox Clav is not something that we would typically see today for treatment. Most notably, we would probably see the 875, 125 milligram twice a day, and often more aligns with a 5, 7, 10-day course compared to 3 days. So that's always something to keep in mind. And then the second trial was also acute renal infection in women, and this was treatment with trimethoprim sulfamethoxazole or ampicillin for 2 or 6 weeks. So the ampicillin was dosed for 2 grams per day, while the trimethoprim sulfamethoxazole was the 320 or 1600 milligrams per day, and that's most notably the double-strength tablets. And they were also given for 2 to 6 weeks. And the primary outcome of this one was recurrent infection rate. And the findings were that trimethoprim sulfamethoxazole actually had a statistically significant reduction in recurrent infection rate when compared to ampicillin. And they also found as like a secondary outcome was that 2 weeks was just as efficacious to 6 weeks. So this is kind of where we kind of see our current guidelines take shape, where we see ciprofloxacin and Bactrim being first line compared to some of our other agents such as ampicillin, which commonly isn't even used anymore, especially as a PO option for our patients with UTIs, versus Augmentin as well. So this evidence, of course, suggests that fluoroquinolones and Bactrim were superior to our beta-lactams, and this was due to an inferior response for the initial treatment success when compared to these other agents for our patients with uncomplicated UTIs and pyelonephritis. They also had higher rates of recurrent infections in these patients as well. One thing to note is when we're prescribing Beta-lactams, they often require higher doses, longer durations, and or both when we're comparing them to the other first-line agents of the fluoroquinolones, sulfamethoxazole trimethoprim, or nitrofurantoin. However, there's been a lot more evidence suggesting that beta-lactams are just as efficacious for the treatment of UTIs, and most of the evidence for this comes from more of our broader agents for the cephalosporins. I'm thinking cefpodoxime, our newer agents, ceftonir. But however, cephalexin is also commonly used for the management of many uncomplicated UTIs today, and this is due to being one of the cephalosporins with the highest bioavailability of about 90 to 100%, and also a very high volume of distribution, and it has very, very high tissue penetration and can get into most of our tissues anyway. However, while Keflex is commonly used and one of the most prescribed agents for UTIs known today, there's a lot of discourse on the proper dosing strategies. So when we think of dosing strategies for our antibiotics, a lot of times we have this discourse between our pharmacokinetics, pharmacodynamics, and our observed clinical outcomes. So this is what this study was looking at, was this difference in the PK/PD versus the observed clinical outcomes. So to get into the study, the methods, the objective was to compare the rates of treatment failure between patients prescribed Cephalexin twice daily versus 4 times daily for the management of UTI from the ED. For some very quick definitions, so they defined uncomplicated UTI as presenting with symptoms of a UTI, which they defined as dysuria, frequency, urgency, suprapubic pain, without signs or symptoms of a systemic illness, including fever and chills, while also having chronic indwelling catheters and urologic abnormalities. They defined complicated UTIs as presenting with symptoms of a UTI, the same as an uncomplicated. However, they did have signs and symptoms of the systemic illness, most notably fever and chills, and also having chronic indwelling catheters and urologic abnormalities. For urologic abnormalities, they actually define this as nephrolithiasis, neurogenic bladder, kidney transplants, solitary kidneys, polycystic kidney disease, renal masses, urethral strictures, benign prostatic hyperplasia, and presence of a ureteral stent. They also defined the resistance mechanisms for cephalosporins, and they defined this as cefazolin susceptibility as for uncomplicated UTIs as an MIC less than 16 micrograms per ml, and for complicated an MIC of less than 2 micrograms per ml. So the design of this trial, it was a retrospective observational single study cohort study. It was run between July 31st of 2016 and July 31st of 2023. They included 214 patients, and they had equal splits down the middle for the sample size. So twice daily enrolled 107 patients, and the 4 times daily also enrolled 107 patients. The intervention specifically was Cephalexin 500 milligrams twice daily or 4 times daily for 5, 7, or 10 days. So for inclusion-exclusion criteria, as you can see, they screened 285 patients, and they included 214 patients. The inclusion criteria included adults greater than the age of 18 who had been diagnosed with cystitis or UTI from ICD-10 codes. They could have mono or polymicrobial infections as long as they were E. coli, Klebpneumo, or P. morbilis. They had to have a cefazolin MIC less than 2 for a complicated UTI, and then less than 16 for an uncomplicated UTI. The patients could also receive 1 dose of IV antibiotics and could have been started on a broader antibiotic and then de-escalated to Keflex within 72 hours of enrollment. Exclusion included diagnosis of pyelonephritis, a creatinine clearance less than 30 mLs per minute if the patient was pregnant, UTI treatment within the previous 30 days, patients with asymptomatic bacteria, current prescription for antibiotic for chronic UTI prophylaxis, and then a urine culture with a form of ANSEF resistance, most notably the MIC greater than 16 for uncomplicated and 2 for complicated. So the outcomes, the primary outcome was treatment failure, which they defined as return to the ED or outpatient clinic with worsening UTI symptoms or modification in antibiotic therapy within 30 days of the principal ED visit. Secondary outcomes, they looked at C. diff infection rates and reported antibiotic side effects within 7 days of prescription. So for statistical analysis, they reported nominal data as percentages and used chi-square or Fisher exact tests to analyze. They reported continuous data as mean with a standard deviation, or a median with an IQR, and they used student t-test or Mann-Whitney U-test as needed for these as well. They also conducted a subgroup analysis where they compared uncomplicated versus complicated UTI, treatment failure with IV antibiotic use, Cephalexin treatment duration, a history of type 2 diabetes mellitus, and then specific isolated bacteria as well. So then to get into the results, this is the table of baseline characteristics. This trial did do a really nice job of actually splitting up the groups and having a very even groupage, and not many or at all of the baseline characteristics did have any form of statistical significant difference. I will say that the biggest difference between the groups was the chronic indwelling catheter. So the twice daily group had about 3 patients compared to 8 patients in the 4 times daily group, but everything else was pretty similar. Most patients did receive 7 days. The most common organism present was E. coli. The symptoms did differ a little bit between the groups. However, they were pretty well spread out between all of them as well. Equal patients had a dose of IV antibiotics, and the most common used was a dose of Zosyn or ceftriaxone. And with that, I think only 1 or 2 patients received Zosyn compared to ceftriaxone. Most patients did also start off with Cephalexin compared to an empiric oral therapy, so that's always something to note as well. The primary endpoint was treatment failure, of course, within that 30 days, and that was defined as the broadening of antibiotics or return to clinic or ED. And the study did find that there was no statistical significant difference between the treatment failure in these two groups. Twice daily had a treatment failure of about 18.7%, while the 4 times daily had a 15% treatment failure rate. For secondary endpoints, of course, we looked at reported C. diff infection within 30 days. The twice daily had an N of 0, and the 4 times daily had an N of 1, but was not found to be statistically significant. And then reported side effects also was not statistically significant. However, the 4 times daily did have a numerical increase compared to the twice daily, which is not uncommon or surprising to me, at least. For exploratory endpoints, this is when they did subgroup analyses. So they looked at uncomplicated versus complicated, the use of IV antibiotics. They included the total duration of treatment, the history of type 2 diabetes, and then the specific isolated bacteria. And they found similar things as well. So treatment failure between uncomplicated was also non-statistically significant. However, it did have a numerical difference where twice daily did have a higher number of patients have treatment failure, but again, not statistically significant. And then the treatment failure between the complicated UTIs was very similar as well, where 4 times daily had that numerical increase, but not statistically significant. And they were pretty similar with 9 versus 10 and 27.3% versus 30.3%. So the authors from this trial concluded that there was no statistically significant difference in treatment failure rates between patients prescribed Cephalexin twice a day versus 4 times a day. However, they did note numerical differences. So they say in select cases, Cephalexin twice daily may be prescribed in patients without an increased risk of treatment failure. So the discussion, some strengths of this trial, it was a very balanced groups. They had exact numbers for both groups as well. They did a manual chart review where they actually were going through patient charts themselves, and it was not AI generated or anything like that based on ICD-10 codes. They included both uncomplicated and complicated UTI patients, and it was very realistic to what we would see in current practices with the use of a callback program for de-escalation within 72 hours. And a lot of patients did receive a single dose of IV antibiotics, especially for our emergency department patients and population as well. It's very common. However, this study was not done without limitations. So, of course, this was a retrospective single center trial. So the outcome was limited to a local EMR, and that could also have affected the outcome as well, just because if patients had gone somewhere outside of the local network and charts were not updated with their current symptoms or broadening of antibiotics as well, we could have missed those patients in the final count. We did not have a confirmation for adherence. So we're totally unsure if the patients who were taking it twice a day versus 4 times a day were actually taking it as prescribed. It was a pretty small sample size that included about that 214 patients. It had a definition of UTI that is a little bit different than what we would think of today, especially with the new IDSA and Wiki guidelines for the diagnosis and treatment of UTIs and the definitions, which we'll get into in a little bit. They had limited feasibility for smaller centers. So Centers that did not have the use of patient callback or culture callback and that ability to have de-escalation might not be able to find this trial as generalizable, even though the patients that did start with broader and to get de-escalated was pretty small. It still is something that we have to consider. They also did not report microbiological endpoints. They only really looked at clinical endpoints, which again is kind of the point of where all this discourse comes from with the PK/PD differences versus the observed clinical outcomes that we typically see for our patients with UTIs as well. So, of course, I don't think I'd be a pharmacist if I didn't at least bring up the definitions for UTIs, especially with the new IDSA publishing for complicated UTIs. So the old classification was uncomplicated were defined as acute cystitis in afebrile, non-pregnant, premenopausal woman with no diabetes and no urological abnormalities. Acute pyelonephritis was an acute infection in women otherwise meeting the definition of an uncomplicated UTI as above, and then complicated were all other UTIs. And the big thing to note with this is that uncomplicated always included men. It included patients with urological abnormalities, and a lot of times also our acute pyelonephritis patients as well. The new classification, however, really opened up the arena for us, especially with the diagnosis of UTIs. So uncomplicated is now defined as infection confined to the bladder in afebrile men and women, and complicated is infection beyond the bladder in men and women, including pyelonephritis, febrile or bacteremic UTIs, and catheter-associated UTIs, and prostatitis. So this really opened up the realm of diagnosis for us, and uncomplicated can now include things like urological abnormalities. Of course, it includes men as well, even though most of our patients that we will see diagnosed with UTIs are these non-pregnant premenopausal women. It really has broadened the diagnosis for us. So in review, there was no statistical difference in treatment failure rates between twice a day versus 4 times a day, with treatment failure rates of 18.7% versus 15%. However, there was a numerical increase in treatment failure for the uncomplicated UTI group, but was not statistically significant. And then complicated UTIs have a higher treatment failure rate regardless of treatment regimen with our beta-lactam agent, most specifically Keflex. And then clinical implications. So twice-day Keflex may be a safe, practical alternative for uncomplicated UTIs in the classically presenting patient. Again, what we think of classically presenting, we think of our middle-aged premenopausal women with the typical symptoms of non-systemic UTIs. This twice-day regimen is cheaper. It has lesser pill burden and may improve adherence. Of course, this study didn't really control for adherence or give us any sort of control for adherence. So we can't really say if the patients who were prescribed it 4 times a day versus twice a day were actually taking it as prescribed. However, with all this said, obtaining susceptibilities is key for the most targeted therapy and de-escalation, and we should always be adjusting our antibiotics to the most narrow agent that we can for the bug that is growing. With all that said, beta-lactams may still not be the preferred agent for complicated UTIs, and we saw that within this study as well. So again, the PK/PD variability. So Keflex, as we know, has pretty high bioavailability and tissue penetration. However, the half-life is only 1 to 2 hours. So this is where we typically get that Q6-hour dosing compared to the study that looked at it twice a day. So this is where we get this big discordance of should we be following the PK/PD or should we be looking at treatment or clinical outcomes? In most cases, I feel like it's very provider specific and pharmacist specific for what they recommend. But I think more studies like this are always going to be coming out and looking at these differences between our PK/PD, what we know, and what we actually see in our treatment and clinical outcomes. With that being said, our complicated UTI patients do have higher treatment failure rates for all groups between this twice and 4 times a day scheduled. So we might have to take a deeper look into what agent we should be prescribing when we're looking at uncomplicated versus complicated UTIs. And with this said, this trial also had a little bit of a difference with definition for our complicated UTIs. So we should also be reevaluating how we treat this new definition for complicated UTIs. But overall, twice a day, Keflex could be a safe and practical alternative for uncomplicated UTIs in our typical patients. And with that, I want to thank you for watching this journal club. And if you have any questions, you can always reach out to me. But thank you so much.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.